So, warm welcome to all of you. As we had all met last week, I'm glad we are not spending time in introduction. And it's nice to see majority of you join back. So just I will start with where we ended last time, a small recap of what was discussed last time. And as requested, like in the last session, please keep it interactive. Please keep it, keep your comments coming. We also end up learning from you, and we also will realize how, where, and what we should focus on. So just a recap of last time, the importance of having Sujit Rajan on the session yesterday was that he is a pulmonologist who is pro-palliative and has actually realized the difference in his practice or improvement in his practice, reduction in stress, and for not only himself, but his patients and caregivers after integrating or having the joy of having a palliative care physician in his team. So just a recap, you'll all agree that there is a rise of non-communicable diseases in India, and that of respiratory diseases. We actually have the 1/3 of the world's burden of chronic respiratory diseases in this country. As pulmonologists, we are also able to cure only 1/3 of all the conditions we see, especially probably we aim at the infections. What we are not, 1/3 is probably where we control, like asthma, COPD, and then there are 1/3 of conditions like primary pulmonary hypertension, interstitial lung disease, and certain forms of lung cancer, which are incurable, right? Now, of course, the pattern of lung cancer has changed a lot. Patients are living longer with the newer therapies available. Now, because the problem is that we all realize that the trajectory of pulmonary disease is unpredictable, but the fact that our patients live a very high symptom burden for a prolonged period of time, it's important to integrate palliative care in pulmonary medicine, which is what we are trying to emphasize. However, there are a lot of barriers onto why this doesn't happen. One of the biggest barriers are that you and me are not trained to think of palliative care. We keep thinking of save, 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 cure, 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 and forget the fact of the unlimited suffering and the health-related suffering that our patients go through. So I'm going to start with a young girl we discharged only last week from the hospital, me and Sujit work. She is a 22-year-old girl who actually came from another hospital with a diagnosis of fibrotic interstitial lung disease. It really upset me to see this young girl who was breathless, on minimal exertion and at rest. And a 6-minute walk test showed desaturation. She was not able to do a complete lung function. Her echo showed a mild pulmonary hypertension, and she was so anxious that she was not ready to come into the consulting at all. And she was already on antifibrotics. Now, 22 is what hit me the most. But if you see any interstitial lung disease, your heart sinks, especially the fibrosing variety. So what can all of you put in suggestions or raise your hand and tell me what is it that you would really can do and what is it that you will do for this patient? Anybody? You can send it in the chat or you can unmute yourself and please talk. What is it that you can do and what is it that you will do for this patient?
Dr. Pooja says offer transplant. Dr. Adasha also says that it is lung transplant, oxygen concentrator.
Yeah. So how easy it is for all of the Indians to access lung transplant? One, availability is one. Organ donation is the second. What about the life expectation following a transplant? So Jaykumar Rajgopal has already reached morphine. Excellent. But what is lung transplant? Let's talk about it. Can we offer lung transplant to all our patients? Availability, cost, fitness, cost after, and how long do patients live after transplant? Anybody? I'm sure all of you know. So the 5 years, yeah. So 5 to 10 years, correct, Pooja? Jay Kumar, thank you. So, we are in a situation where now we can offer lung transplant. But the problem is the availability of organs. Second, the problem is the cost. And this family history of this girl, her father doesn't have a big business. Her younger uncle has got stage 4 cancer. She has two grandparents and a mother who is the one who goes from hospital to hospital. So the whole idea of putting this situation was, there's a young girl, not so rich family, difficult financially, socially, there are not much people, and we have this situation. How do we handle this family? It's not just enough to suggest, go get a new lung. It's going to be very, very important, very, very difficult. Yes, Dr. Sanjay Pandya has said rehabilitate, exercise tolerance, palliative management. So this is what is important, and this is what we are going to talk today. So this situation becomes even more difficult because this girl is only 22. Yes, lung transplant is an option, but it cannot happen tomorrow. And therefore, we need a lot of things to be done before that. So this brings me to what I think I talked to you about it last week, which is the breathing, thinking, functioning model. All our patients of advanced chronic lung disease are stuck in this vicious cycle. They all are breathless because of the underlying pathophysiology. Because of the breathlessness, they are anxious. And because of the anxiety, they don't move and they get further and further deconditioned. And this is where the integration of palliative care, like how Sujit introduces me to the patient and his family as a member of the team who will improve the quality of life and symptom control. So the physician and all of you pulmonologists, the busy pulmonologists, can look after the lung and do all the things necessary to see to it that the patient is comfortable, maximum optimized treatment. Involve a counselor so you address the patient's fears, anxiety, beliefs, desire, and see to it that you tell the patient we will not do anything that you don't want us to do. Then you have to also involve the physiotherapist or the pulmonary rehab, like Dr. Pandya suggested, so that activities of daily living for that patient becomes bearable. So this is the multidisciplinary approach, along with nurses, social workers for funding, volunteers of those patients who have looked after patients with interstitial lung, who can handhold this. So this is exactly what we have started for this young girl. She's on antifibrotics. She's on LTOT. We've actually managed a crowdfunding and given her a portable oxygen concentrator so she can move about and her life can be little bit normal. She was so anxious, she really needed a counselor. So she has a counselor whom she talks to regularly, and we've put her into a pulmonary rehab program. In the meantime, parallelly, we are also talking to her about meeting the transplant team, giving her an idea of the budget so that she knows what she's going for. At the moment, she's not ready for a transplant. Even the thought of the transplant is upsetting her. So therefore, this is what we need to understand today, because it is a very diagnosed and therefore undertreated condition. This term of chronic breathlessness syndrome was actually coined in 2017 by a Delphi process. What you need to understand is, irrespective of the cause, it could be lung cancer, it could be motor neuron disease, neuromuscular disease, congestive cardiac failure, or advanced chronic lung disease. When a patient is on maximum medical treatment and then continues to be breathless on minimal exertion or at rest, and this breathlessness is affecting the patient's psychosocial life or quality of life. When that happens, that is defined as chronic breathlessness. And it is irrespective whether it is 1 day, 1 hour, 1 week, 1 month, or 10 years. The point is, we need to elicit this history. And it is very important, therefore, to ask the right questions to patients, right? What is it that you have given up because of your breathlessness? Every time when we follow up patients, we say, are you better? Is the medicines better? Are you feeling less breathless? What we need to focus on is what is it that you have given up? So when we are training to be doctors, our focus is so much on pharmacology that we forget the non-pharmacological, the importance of non-pharmacological things. So especially if you have typically a patient of COPD, okay? He's come once to the hospital, twice to the ICU, third time to the ICU. Often we hear the doctors say, now there is really nothing much we can do, don't come to the hospital. Or they keep coming back and they keep getting admitted to the ICU. So this non-pharmacological thing is a huge step before hospitalizing these patients, and also gives the caregivers an opportunity to do something before calling 911 or the ambulance and rushing to the casualty. So simple things that all of you know, like for example, if the patient is chronically breathless and he has an acute episode, You teach them to wear loose clothes, sit in a well-ventilated room, maybe next to a window, position the patient as per his comfort, distract the patient with music or relaxation technique that the physiotherapy has taught. These days, there is cognitive behavioral therapy for chronic breathlessness, especially in neuromuscular conditions as well as in interstitial lung disease, where the patient is taught to breathe in a particular way. Then the most important and evidence-based is a handheld fan. So a battery-operated handheld fan works wonders. If you tell the patient's caregivers to put that battery-operated fan blowing into the patient's face, into the nose and mouth, there have been studies showing serial MRIs where the brain stem actually, there are changes in the brain stem where the respiratory rate actually settles down. So the point is, there is multifactorial reason for the patient to get breathless. And once he gets breathless, he gets more anxious. So all these things target the other reasons for breathlessness, and therefore the patient's respiratory rate comes down. It's important, therefore, to encourage and make the relatives learn non-pharmacological techniques. So please do Google search. I'll also send you an article on handheld fan and chronic breathlessness syndrome. It's very cheap, it's very effective, and in a country like India, in this hot weather, it also helps the patient relax and calm down, and the patient's respiratory rate settles down. There is never, and I cannot overemphasize the need for pulmonary rehab. Every patient must be made to do some exercise, because exercise releases endorphins. So there are happy hormones. Patients can get a little more independent. Nobody likes to be cleaned or bathed or dressed if they can do it on their own. So just like you and me need to train to run a marathon, our patients need to train to do this bathing, going to toilet, dressing up. And if they do that, they feel more and more confident. The other thing that we focus in palliative care is to ask patients what gives him joy. And if activities like, say, gardening, playing with grandchild, or talking on the phone with friend is what gives him joy, then we help the patient plan and prioritize that. So whenever the patient is more energized, so say in the morning or the afternoon, that's the time we tell him to do it. Suppose a lady likes to cook, then we tell the attendant or somebody to prepare everything for her, and then she can just add the spices and she gets the joy of having cooked for the family. So the point here is to focus on the quality of life, focus on individual things that give you joy, because happiness is different for different people. So you know how we have been trained as doctors to improve the physical symptoms. Palliative care goes beyond to make some use and put utility into the patient's life. And like the other doctor had mentioned, for this bunch of elite pulmonologists, I don't have to go through the pharmacological treatment, except for the fact that I need you to introduce you to morphine, as already been suggested by another uh, doctor. So what we do in morphine is, it is a low dose morphine. We start low, go slow. We in Bombay have only immediate release, and we start with 2.5 milligrams in the morning and 2.5 milligrams at night with laxatives. You must prescribe laxatives with morphine because morphine causes constipation. So this is an interesting paper which is published in the Canadian Journal. And as you see that the patient is progressing from diagnosis to end of life, the stepwise treatment for COPD typically is, you all know about the inhalers, you all know about the new inhalers, oxygen therapy, pulmonary hypertension. But as the patient's gold standard 3 or 4 arrives and the patient is more breathless at rest or minimal activity, you should start the patient with first SOS opioids and then regular opioids, because this improves the quality of life. Opioids act by reducing the work of breathing. It acts centrally, so also reduces anxiety. It decreases the respiratory rate, so the depth and the tidal volume improves, and the patient only feels less breathless. Okay, so there is a sensation of reduction of breathlessness. We must tell the patient that I'm not treating your COPD. You have to continue all the inhalers. You have to continue rehab, your counseling, but morphine just reduces the sensation of breathlessness. So respiratory rate becomes less, patient feels more confident. So I have had patients in the past 5 or 6 years who've actually first come by wheelchair, And the next visit on morphine, say follow-up of 8 weeks, they actually come walking, they have time to get dressed, and they feel good about themselves that even in this given circumstances, they are able to do these small things which gives them joy. See, you and me cannot focus and increase quantity of life. We are not God. But the time span that we have with our patients, they can live life better. We can make them improve their quality of life and really see to it that they do what really gives them joy. So as the patient's condition deteriorates, when the patient is say MRC grade 4 or 5 is when we introduce morphine. Okay. So again, so this is the stepwise approach where we first, when the patient is chronically breathless, you start with the pharmacological treatment, that is the non-pharmacological treatment. Consider then SOS opioids, then long-acting, and then of course end active dying or end stage is when I will talk to you in the this thing. So Dr. Jayakumar has written that my personal experience is good, but many pulmonologists are hesitant about type 2 respiratory failure. It's correct. So the point is we are not trained about morphine, Dr. Jayakumar. And if you have type 2 respiratory failure, anyway, you will use BiPAP. So when you use BiPAP along with morphine, BiPAP takes care of the washing out of carbon dioxide and morphine reduces the breathlessness. And morphine also causes the patient little bit drowsiness, so he cooperates better with the NIV. So I have seen that patients do well if you combine the two, especially if you have established type 2 respiratory failure. Lot of pulmonologists have reservation about using opioids. But please remember that when we use these opioids, they're always so low dose that in the past, no, there is no published literature of respiratory failure and death because of opioids. Here, the intention of giving opioids is only for comfort. So it's very, very low. Okay. And we do not go beyond 20 to 25 milligrams ever in 24 hours. So if your patient does not settle down with that high dose, there is something else happening and you need to explore for anxiety, breathlessness, something else. A patient is not compliant. We never go beyond 20 to 25 in 24 hours. Abroad, they use a sustained release and they give a BD dose. Okay. So please remember, always start low, go slow. Have the conversation about opioids. Yes, it is a narcotic. Yes, it is used for cancer pain, but the doses we use in breathlessness is so low that the patient's only sensation of breathlessness becomes less. The other important publication that was done is, see, like we all say, we cannot change the outcome of the patient. So if you see this red line and blue line, the red line are patients who got palliative care along with their treatment for breathlessness. And the blue line is patients who did not receive this support service. So the support is holistic, emotional, psychological, pulmonary rehab, medical, and pulmonologist. So you see the patient's quality of life with the red line is markedly high compared to that without the support. So it's just imagine you and me, we usually doctors are terrible patients. So if you and me, because we have friends, they keep in touch with us, they come and visit us, they give us say take us for a drive. So these are all different forms of palliative care. That is what our patients need. Just like how you and me need support when we are not well, they also need to have that kind of support. So this is very important to say that there is documented evidence that integration of palliative care service, hand-holding patients and caregivers improves the journey. And not just that, you also must have read the famous 2010 integration of palliative, the TEMEL paper, where they have clearly said that early integration of palliative care in lung cancer definitely improves not just the quality of life, but patients also end up living longer. It's just the fact that the patient feels much more supported. Yeah. Dr. Shetty, about the morphine part, yes, anybody, so the rationale in this country, Pallium will be able to tell you better, is that if you have a training in palliative medicine along with your degree, yes, you are allowed to prescribe. please see to it that if you're working in a hospital, please see to that if it's a registered medical institute, you get license to stock morphine also. There has been a lot of change in the NDPS Act, which has changed in 2014, and therefore the rules and regulation to stock morphine is not as laborious as it used to be before. So that Pallium, please share your concerns with Pallium and they will get in touch with you. So the other thing, which is very typical, as I was discussing even in the group yesterday with Pallium, where the minute people get breathless, they all stick to oxygen. Please remember that hypoxia is not related with breathlessness. And also all patients who are breathless are not necessarily hypoxemic. So please don't use oxygen freely. I don't need to tell this group. We need to be sure we don't give oxygen if the pulse oximeter shows more than 88. So please understand this, that we should not abuse oxygen and use oxygen judiciously. Yeah. So that is important. Now about the dosing of morphine. So this is the way morphine acts. And we usually, the way we start is first SOS. Let the patient get convinced that morphine is making a difference. So we tell them to take it before an activity, 15 to 20 minutes before a bath. And then he says, yes, I felt better. I didn't come out like a ragged doll. I could come out, wipe myself and wear clothes. So then we start twice a day. Then after a week, we make it thrice a day, then 4 times a day. So the half-life of morphine is 4 hours. So whatever dose you give, it is washed out in 4 hours if the kidney functions are normal. So effectively, we reach that thing of every 4 hours. And normally it's 2.5 milligrams that we give every 4 hours with laxatives. And like I said, the maximum amount I have given is 20 milligrams, where I have given a lot of morphine for breathlessness is motor neuron disease. In motor neuron disease, there is higher doses of morphine required for the chronic breathlessness that patients experience. Okay. The next important thing, so this is another graph that you can, slide that you can remember. And anyway, these slides will be shared. So we start low dose. When you start oral and you suppose you have to convert to IV, then you give 1/3 the dose in the IV or in the subcutaneous. So please remember that very often you have to emphasize that the patient takes all his regular medications. If opioids do not settle the breathlessness, like I said, you need to start exploring for anxiety and panic attack, and therefore start adding those medications like medium-acting benzodiazepine or a long-acting benzodiazepine, because anxiety can be a big role for these patients. So please remember this. Okay. So it is a wonder drug. It is a safe drug. It does not morphine as such will not make hypercapnic respiratory failure. And if there is existing hypercapnic respiratory failure, please use BiPAP along with the morphine. Okay. So, okay, Hasmat has shared some information regarding that. Then we come, any questions so far or any thoughts or any comments? I can stop sharing and we can talk and go back. Any thoughts? Any doubts? Any suggestions? Any anecdotes? Any use? Anybody has used morphine for chronic breathlessness?
Madam,
Yes.
not about the morphine, but myself,
Yes.
Dr. Sanjay Pandya.
Yes.
Actually, I wanted to know about the use of a ABG investigation, because a lot of pulmonologists, they are not using that frequently, that investigation, which is very important to see the lung function.
Which is
how is the
arterial blood gas?
Yeah, arterial blood gas.
So first of all, I think
it is. I think it is underused, that investigation.
So I think it depends on where you are, Dr. Pandya. If you're in an urban area, availability of ABG is easier. Now, problem is when the patient has said, I don't want to get hospitalized. So when you look at a palliative care angle of chronic advanced lung disease, and then we actually say we should not do ABG because it's very painful, patient is at home, patient doesn't want to go to hospital. But if you are thinking of I think it's the best done in a hospital. So if the patient is ready to get admitted, then yes, it should be considered. And if the patient the goals of care is not decided. But in a palliative setup, we actually avoid very difficult procedures. I mean, especially arterial blood gas.
It is not, madam, so difficult. It can be done at a home level if the person is capable enough to do it, because only
I agree.
pressure is important.
No,
nothing
I
else is.
agree.
And availability within 5 to 10 minutes of 2 to 5 minutes of a distance of hospital. I am talking about urban only, but a lot of pulmonologists, they are not they are reluctant to get that investigation done usually.
See, also it's painful. So if you had an ABG, like patients of
Even
COPD
after giving
child,
local also you can do.
yeah, correct. So for that matter, I feel even lung function tests are very poorly
Yeah, it is also
utilized,
poorly
very
advocated. And before
underutilized.
doing a test, even they start bronchodilator and everything.
And not just that, very often lung functions are done not just it's not even complete. There is no bronchodilator reversibility. There is no 6-minute walk test. There is no
Yeah,
DLO. So we are anyway getting incomplete. So so many investigations can be done, which should be done. But the focus here, sir, is mainly on those patients who are advanced, where we are focusing on the quality of life, where the goals of care has to be discussed about how they would like to be treated in an emergency. So
Yeah.
acute care, when the patient is in the initial stages of his disease trajectory, all this is extremely important. And I cannot emphasize more the need for a lung function, the need for a blood gas. Only then you will know if the patient is type 1 or type 2 respiratory failure. So it was a good point. We should use these available investigations more and more. Okay. So thank you for that. And thank you, Rajni, for adding that VBG can be done, which is important because we sometimes need to know a venous blood sample can also give you an idea of the carbon dioxide. And what is important is pulse oximeter doesn't give you the carbon dioxide level. So sometimes you need to get to that carbon dioxide level to know why this patient is not improving.
This is because why I told you, because I've seen lot many COPD patients who were reached up to the palliative level but still never done a ABG. So baseline you don't have.
True. No, definitely. At the time of diagnosis, you cannot diagnose any of our lung diseases without these basic investigations now of a scan, complete lung function, blood gas, and ABG is a part of lung function, as well as 2D echo, because cardiac implications are plenty in chronic diseases. Correct?
Yeah. Thank you.
So thank you for that, Dr. Pandya. So now we come to main important thing you need to remember about chronic. One is the term chronic breathlessness. Two is the fact that non-pharmacological. Please talk to your physiotherapists, counselors, and teach the caregivers the non-pharmacological technique, handheld battery-operated fan, and low-dose morphine. Very, very important. What if the patient comes in an actively dying phase where he's extremely breathless? And distressing symptom, is distressing for the patient, distressing for the family, and that is where we talk about the terminal breathlessness. And it can be seen across, it's not just the lung diseases, like I said, cancer, MND, CCF, even neurology, CKD, when patients are actively dying. So this is terminal breathlessness, which we call as palliative sedation. Now, please remember, the intent for palliative sedation is comfort and addressing distressing symptoms. Medically and ethically, this is in the best interest of the patient. We are not giving a whopping dose of medications to end life. That is not our point. We are pro-life, we are pro-dignity, we are pro-comfort, and we want the patient to die peacefully or transition peacefully. Because even for the caregivers, the manner in which a loved one dies is etched in the memory of those who live on. So if you've lost a loved one and it keeps playing back in your memory, especially if it's been a horrible death, for example, in the ICU for prolonged state, or multiple hospital admissions, poor quality life, completely stripped of dignity, it keeps playing on your head. So typically this is important, but this needs very good communication between the palliative care team and the patient and the family. We document it, and it is typically used when the patient is actively dying. So when there are signs of actively dying, for example, low oxygen saturation, low BP, low urine output, probably, a patient who is obtunded, not conscious, respiratory rate is shallow, type of respiration is different. And that is the time we then start the patient on a subcutaneous infusion of morphine with midazolam. Start low, go slow. We really give only 10 milligrams each over 24 hours through a syringe driver. And typically it's given over, not more than 2 to 3 days. And that's when the patient transitions in peace. So the idea here being that patient dies in his sleep, not aware of his distressing symptoms. But the fact is the patient may become unresponsive. So it's important to communicate and document all this, and therefore see to it that we need to get the family also on our side, that this is the best way for the patient to move on. It's very hard for the patient to keep struggling to breathe and then die, right? How to give 24-hour subcute injection? Yes, it is given by a syringe driver. It is given with you could give it with a small scalp vein, 26 number needle. Just like you patients take insulin under the skin, you pinch the skin and you put it under the skin. So typically this can go for over 24 hours. You can change the site every 24 hours. And it's the most painless way of giving any parenteral injection in palliative care. We avoid intravenous, we avoid intramuscular for sure. We use things like buccal, transdermal, perrectal, subcute, so that it is less intrusive for the patient. And we the most important thing is we also do this at home. So if the patient is affording, we have a nurse, we have a family GP, and yeah, great, Hashmat. So that is important. So this is we there are patients whom we start this at home. These days there are syringe drivers available in the market. So we give that prescription and the patient is kept comfortable at home. So this is also called as palliative sedation. The intent is not to end life. The intent is comfort. So please remember all the legality of palliative sedation is sorted with good communication, the one that Hasmat is going to share. And you must remember that, yes, the outcome of palliative sedation is death. But the quality of death is also important, or the quality of life before death is important. Any thoughts or comments before I move on to cough and other this thing? Okay, dilution. So usually we give, so the dilution is usually 100 ml. That I think Hasmat will share it with you. But usually we give it with a, in a syringe driver. So it is given over 24 hours. So all those details, the technicalities, we will share in the group. Absolutely. Okay. Any thoughts, any comments, any reservations of using morphine before I go on? Rajni, do you want to share something? Since we have another expert pulmonologist who is pro-palliative and into ICU.
No, I think you've covered everything wonderfully, Rajam. It's just like the entire non-pharmacological to pharmacological. I think the seeing as the questions have come up, the information that Hashmat's going to share in the group is going to be useful for everyone.
Okay, thanks, Rajni. Okay, so we go to cough. And I think now you all must have seen the latest paper of how there has been a paper where they've discussed about morphine being helpful for cough in ILD. So we all know that, persistent irritating cough can be extremely distressing, not just for the patients, but for the caregivers, wherever he's sitting in a, for example, in a concert, in a puja, in wherever, if the patient is constantly coughing, can be very irritating for everybody, right? So the whole point here is how can we address this patient? All of you pulmonologists definitely know what is the dignity of dying? Do you want me to take that in the end, Dr. Karthik? I'll finish this and we'll talk. It's an interesting question. Okay, so it definitely affects the quality of life, right? So we need to think about what we should do. And there are patients very often with stroke, with locked-in syndrome or permanent vegetative state, or those patients who are on tracheostomy, who are getting fed through the Ryle's tube. We see that a lot of patients have copious secretions. It need not be only respiratory patients. It can be even non-respiratory patients with copious secretions. So secretions is one thing that we need to realize. First thing is, of course, the amount of feeding that goes on in the ICU. Unfortunately, that volume is sometimes more than approximately 2 liters. So you have elderly patients who are in the bed, who are not moving, and who get more than you and me who are on our feet. So we really need to rationalize the quantity of food that we are giving. How are we managing the bed change, the positioning after parenteral feeding? And then what we do is first rationalize the volume of feeds so that the regurgitation and the reflux becomes less in these critically ill patients. And instead of doing suction, which is extremely traumatic, especially in patients who are, moribund or even awake, imagine that thing going, gar, 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 and all the ulcers being formed in the oropharynx. Try to reduce the secretions by using hyoscine, that is buscopan, or glycopyrrolate, so that we can actually reduce the secretion, do chest physiotherapy, hydrate the patient only enough, change the position, bring the secretions to the mouth, then you can do the suction. So don't go beyond the oropharynx to do the suction. So hyoscine and glycopyrrole are the two drugs used for reducing secretions. Hyoscine, the dose of 10 to 20 milligrams, again can be given subcut, and glycopyrrolate in the dose of 0.2 to 0.4 can be given. And this does work very well if it's combined along with the reduction in the RT fields. Now, the cough, again, it could be because of multiple reasons, not just respiratory. So you need to, with your expertise, evaluate where this cough is coming from and first introduce the non-pharmacological treatment. So if it's gastric cough, lifestyle changes, small frequent meals, early light dinner. If the patient is able to walk a little bit, a stroll before bed, propped up position, all these things are important. So lifestyle changes are extremely important. The pharmacological therapy, yeah, so glyco, if we actually break it into small pieces. We start even with 0.5, Karthik, and we do give patients, and if the moribund patients, we can even give subcut. So lifestyle changes for cough is important, like, hot water, checking reflux, whether the patient is in imminent pulmonary edema, then you can even use non-invasive ventilator to control the cough. So all diuretics can be titrated. So these things are important. But the other important thing, pharmacological, of course, is to see to whether the patient is using inhalers correctly. Elderly patients, maybe you need to switch over to nebulizers, all this, right? But what is important is now the role of codeine. Unfortunately, again, not available easily in Bombay. Many chemists don't store it, but persistent refractory cough, you can try with codeine syrup. Next step is morphine. And please remember, even codeine causes constipation. So please prescribe laxatives if you have given codeine. Now, morphine, typically the paper has said that it can benefit people with ILD cough. So the constant hacking cough, just like how you treat the breathlessness, in the initial stages of interstitial lung, when the patient is not that breathless but has a persistent hacking cough, the paper has been shared with you, I think, or I can share it, about ILD benefiting with morphine. In a context without ILD, when there is persistent cough, you have tried the non-pharmacological gabapentin has shown some promising results. So, for example, in patients with metastatic CA, constant irritation of the pleura, there's constant hacking cough, you can try gabapentin in the night first because it's sedative. So actually patient sleeps well, improves that aspect of the patient is improved, and then you can actually start during the day, and a dose of 300 to 600 milligrams is known to be helpful for intractable cough. Okay. Okay. Then we come to another distressing symptom, which is pleural effusion. Now, how do we palliate pleural effusion? Again, very, very important, because usually it is malignant and recurrently filling, and that depends on the prognosis of the patient. So the patient has a good prognosis, then what we do is put in a small ICD, a pigtail, and then we can actually plan for the talc slurry. But if the patient's prognosis, so when his performance status is poor, then we just do aspiration, but manage the breathlessness and pain with morphine, with non-pharmacological things, and see to it that the patient, is managed well, as conservatively as possible. And we need to talk to relatives and patient, because it can be very distressing to keep coming to the hospital for aspiration. So yeah, pleurodesis or talc slurry, but that is if the patient has a good prognosis. We suggest that with a pigtail or this thing. I also wanted to touch upon the COVID pandemic and how it has affected all our lives. We cannot afford to forget 2020 to 2022. And I think if we had all been trained in palliative care, we would have been probably better equipped to deal with the pandemic, because it was right from the fact that we didn't know how to handle masses of patients. We didn't know how to triage these patients. We struggled to decide which go to ICU, which don't go to ICU, which come to hospital, which stay at home. The conversations about patients not improving, therefore not to put on ventilator, the conversations about withdrawing patients from ventilator, and multiple losses in a particular home. So all these aspects of palliative care, if we are all taught, I think the next pandemic, God forbid, we'll handle it better. It's very, very important, because all of us went through psychological, emotional, financial, social, physical distress, not just patients. with COVID, patients without COVID, their family members, you, me as doctors. So we must remember that there's a huge role of pandemic in all humanitarian crisis. And that is the time when medical ethics should be really put into place, because we need autonomy. We should do what is in the best interest of our patients. We should do everything to cause no harm, and justice, because we do not have 1.4 billion ventilators and counting, right? So we need to decide which patient benefits most from that and be able to have those difficult conversations of not putting certain patients on ventilators and giving him a dignified end, right? Selecting the right patients in the ICU, communication with caregivers, which is your next topic. And something that Rajni does and really strongly believes in is how can we actually integrate palliative care in all our ICUs and in our casualties, because those patients who should not be put on aggressive treatment should be having withholding care, but they have the right to be comfortable, and that is our duty. And those patients are already on ventilator aggressive treatment, when they're not improving, we should know when to withdraw, how to have these conversations. So the next few sessions will be how to have these difficult conversations, to discuss the legality which is existent in the country, and to discuss the medical, ethical, legal indications of withholding and withdrawing. And therefore see to it that we remember we die only once, we live every day, and we need to see to that our patients also live every day with a good quality of life with the recent modern medicine. At the same time, as pulmonologists, we should all know when to wear the palliative care hat for that particular patient and talk to the patients according to that. So with that, I end my presentation and I'll go back to the chat. In the meantime, Rajni, is there something else you want to add or I have missed out? Yes, thanks, Rajni, for the catheter. And this dignity of death is what I'm going to address. But Rajni, anything else you would like to add?
No, in terms of this, there was a question when I mentioned Pleurex catheter.
Yes.
And one of the comments was about complications of a persistent pigtail or a catheter in place. Well, the first principle of any of these things is an open communication with the family and defining goals of care. So if we are looking at the risk benefit of, okay, one catheter, one stick, teaching them the good care at home, and then that's the benefit is reduced hospital visits, more time for the patient at home, not as much pain going forward, greater control for the patient over their management of their pleural effusion. So yes, there's going to be pros and cons to any therapeutic choice that you make. It is about making sure that the choice that you're making is in concordance with the patient and the family's goals of care.
Thanks, Rajni, and thank you, Karthik, for the cough questionnaires that you use. About the dignity of death, what is it exactly that you would like to, I mean, what are your thoughts? I think Karthik asked that question. So what is it, where would you like to steer this discussion? Because it's an entire topic on its own. So where is this coming from is what I would like. Karthik, I'm waiting to hear you. End of life. Yes, correct. So, this is a topic where how I would like to begin this is how do you all think of your, first of all, have you all thought of your own mortality? How many people have? You can raise your hands. Have you thought of your own mortality? One yes has come from Sonali. As doctors, we are the profession closest to suffering and closest to death and dying. Yet we do not talk about death. We are not comfortable using the word death. So many people have raised their hands. So how would you like to die is my next question. The ones who have raised their hand. It's not a morbid question because I think the funda in palliative care is that death is inevitable. A bad death is avoidable. So we need to realize this very important sentence that all of us will die. But at the same time, it should be our decision, our life, and therefore have fair amount of control over how you would like to exit this world. So I have grown up listening to this mantra from my grandfather where they say, Anayasena Maranam, Vina dainyena jivanam. Oh Lord, give me a death without suffering and a life without illness. Modern medicine is somehow, yes, extremely beneficial. ICUs work like magic to put quality of life and resurrect patients into good life. But we also 25% of our patients shouldn't be in the ICU in the first place. A lot of unnecessary, futile, aggressive medical treatments are done in our ICUs for prolonging life, or what we call as life-sustaining treatments. So we need to think about what is death. How do we all want to go? So naturally, not in ICU. Now, what is natural death? So everybody wants to wake up dead. So basically die in their sleep. It is not happening because only 7%. Correct. So only 7% die suddenly. The rest of the 93, according to statistics, die either bedbound 1 hour, 1 week, 1 month, 1 year, 10 years.
Rajam, may I share my screen for 1 second to illustrate your point?
Sure. So the point what I'm trying to make is, and usually young deaths happen under the age of 50. After the age of 50, the chance of young death is also going down. And modern medicine doesn't let you die in peace. We do not let nature take its course. Beyond a point, we as doctors know if a patient is got a severe acidosis, a PO2 which is in the rock bottom, a BP which is low, is not going to make it with good quality of life. And that is the time that we need to actually start palliative care. But talking about palliative care at that juncture is too late, because nobody has the mindset to talk when the patient's loved one, the caregiver's loved one is in the ICU. You need to therefore integrate palliative care much before, so that the patient and the family is ready for that. So this is this graph that I had shown last week briefly with Sujit, where the trajectory of how people die, right? Sudden death, where there is no time for palliative care. The B graph, where there's terminal illness, typically a graph of a cancer patient where enjoys a decent quality of life and then slow decline. And then this is where we all come in, where lung, heart, liver, kidney, neurology, where we see the patient only in acute exacerbation. And what happens to this patient when he goes home? Is he self-caring? Is he able to eat, talk? What is the dignity? And any chronic illness strips the human being mercilessly of his dignity. The fact that you and me, suppose we have a fracture of the leg or fracture of the hand, somebody else has to dress us, somebody else has to clean us. It is extremely difficult for us to accept help from others. Get me water, take me to the toilet, wipe my back. It is something that our patients live every day for 5-6 years. It can be extremely, what do you say, poor quality life in terms of how he sees himself. So, I mean, relating again from a personal view, when my father passed away with a stroke, the 2 years before that, he was not independent walking, he was wheelchair bound, but he used to do small steps. When his friends came to meet us after his demise, they said, your dad used to tell us every day, please pray I don't see you tomorrow. Because what is this life? I can't open the door. I have to wait for the ward boy to take me to the toilet. I cannot even pick up the phone. This is useless. This is not the quality of life I want. And I, as a doctor, thought I was doing everything for him. He should not have any reasons to complain. He could go out on a wheelchair. He had somebody to, on the press of a button, there was somebody to attend to him. It's a great life. Despite the fact that he had so many issues, he still had a great life. There should be nothing to complain. Then I realized that that is not life. If you and me are told to stay in bed for one day, it's irritating. What happened to all of us in COVID, where we had forced loss of freedom, how it feels. It is so claustrophobic and suffocating. But our patients live like that endlessly. So dignity is a very difficult word to describe. It is to each his own. Having said that, if we can manage to give a patient symptom control, ask him what matters to him, what really does make a difference to him or her, and try to give most of that, we've at least achieved. And the point is, we might not be able to achieve everything, but the fact that we acknowledged his need, acknowledged his distress, and the fact that, yes, I can see this is distressing, I will try my best to help you, we will support you, we will do our best. These are the things that patients want to hear. You and me are not God to make the COPD go away or the ILD go away. So the outcomes might not change, but the journey becomes bearable. You have a friend, a mentor, a supporter. just imagine when you are going through a difficult phase, when you have friends and family just sending you a message in the morning, how are you? Did you sleep well? Have you had time to, have a coffee? Should we go out? Those things make a difference. And that's what palliative care team does, where you have a nurse, there are various levels of support, physiotherapy, counselor, social worker, volunteer, so that the patient is in the safety net. And even if he finds it difficult and intimidating to talk to doctors, he has other people to talk to so that his needs are addressed. I'm not saying it is all solved, but at least he's able to express. And sometimes you will agree that when you share something, 50% of your problem is like, I'm relieved. It's out of my system. I have vented it to the right person. So that is what is dignity to me. I don't know if anybody else would like to add to or have experienced this in your inner circle, your family, your grandparents. And it's very important to, they are vulnerable, they're elderly. We should ask them how they would like to be treated much before they reach the casualty. And very often I have heard this statement saying, we never thought something can happen to my 88-year-old grandmother. We never thought she will fall sick. We never thought of this, which is a bit difficult, So that is the onus of doctors and family physicians to ask, because they're already thinking of death. They're scared of the manner of dying. Will I be in pain? Will I suffocate? Will I be choking? So all these thoughts are going on. It's just that we are not trained to ask them. We don't talk about it because the patient doesn't ask. It's very convenient. You didn't ask, I don't have to tell. But it is our onus, because we have seen so many more COPDs and so many more interstitial lung disease patients than the patient. So whose responsibility it is to foresee and foretell? It is the doctors. It is the pulmonologists to say that this is what is going to happen and how would you like to be prepared? Because these decisions cannot be made like this over one consult. So great question, Chaitanya, how much does palliative care cost? In this country, a large amount of palliative care is done by NGOs like Pallium. But they focus a lot on cancer initially. It's now that it's opened up for non-cancer. Private palliative care is like any other profession or vocation. So we are treated like the consultant of a pulmonologist, neurologist. We get the same OPD charges and we get the same, consulting charges. But by and large, unfortunately, it's still not under insurance, right? A large amount of palliative care. So when palliative care is done at home, it can be expensive for the patient, but please, nothing like an ICU for 4 weeks or 6 weeks. So, in comparison to that, the cost ratio, health economics wise, it's good for the patient, it's good for the hospital, because the rapid turnover of that same bed, instead of one bed being occupied by one patient for 1 month, all of you will agree that after the first week, the investigations taper. You rather have a patient occupying that same bed, rapidly turning over, sending him back to the society with good quality life. And therefore, the first week is where you have maximum investigation. So health economics wise also, it makes sense to have patients who will recover and go back to society and rejoin and lead a productive life. I think I've spoken too much. Dr. Sanjay Pandey has something to say. I think long assisted care home should be delivered for better comprehensive. So, assisted livings now, Dr. Pandya, in our country, we still had a social fabric. It is fastly diminishing. We had children, many families had big families. People used to take time off or work off and look after parents. That is fast going. So my generation will need to go to retirement homes and assisted living. We are the sandwich generation where we've looked after the previous and the next. But unlike the West, the social fabric in this country still exists. You still have parents living with children as of now. Next generation, that's going to fast disappear.
Madam, sorry to say you, but it is just a show off. Social things are. It is never taken care of in a way it is to be. So if it is a professional care is given, it is always better. I feel like.
But professional care is also not affordable by everybody.
Yeah, that is true. But those who can afford, those who can afford,
okay.
And I think even the government will also come up slowly and steadily for taking the care of
urban
senior
areas,
citizens. I
there
think
is no place.
the positivity is there.
In urban areas, there is no place. It has to be middle of nowhere. And then the middle of nowhere has to have good palliative care. We cannot afford to have poor palliative care, because it has to be robust and it has to be holistic, and we have to look after every need of the patient. So
true.
challenging.
True. Challenging, right.
I think, one of the things that I'd like to point out here is that, as Dr. Rajam just mentioned, it has to be good quality palliative care. One of the problems with the way palliative care has been viewed in the past is that it's an act of charity, or it's doing something at least for comfort, but it hadn't been as much of an evidence-driven practice. You've seen her mention multiple studies which tell you how and why these drugs are useful for symptom relief. And we're talking about symptom relief and quality of life, which actually in as a second effect, like even when you look at Dr. Temel's paper that she mentioned from 2010, the same Jennifer Temel's group has done another paper which shows you an increase in survival. What's happening with the early introduction of palliative medicine into patients with chronic respiratory diseases is that we are truly listening to our patients' problems, solving them along with taking care of the disease. That leads to a better buy-in by the patient, adherence to their medications, adherence to the regimens, because they know that their doctor is really trying to do their best. Oh, no, I won't say doctor, their team is trying to do the best for them. What you say, sir, is absolutely important, that we need high quality stuff. Palliative care in some contexts has been called slow intensive caring. So it's not intensive care in an ICU, but it's actually taking care of every little detail, whether it's electrolyte, fluid imbalance. You mentioned ABGs. The reason why I said BBGs, I agree with you. Just because the patient, if a patient is okay with a blood draw, then I might try to bargain down and see. That'll help me titrate their BiPAP and their morphine. So that is the way we practice nowadays. It is evidence-based. It's high quality. The problem is when we talk about the cost of it, so far, the community at large and the corporate hospitals have not yet found it to be a valuable service. That is something we as practitioners can help in sensitizing the patient population about the value of early palliative medicine, right? So if you see Dr. Rajam's practice setup where she's practicing in corporate hospitals, so am I, there's a slow and steady increase in the number of patients who realize the value of that. Not everyone is ready to pay for it. Not everyone's ready to pay for those services, but those who are should be offered.
It has to be with a charity organization like Pallium, like something like, it's not a corporate culture job. I think so.
Exactly what I'm saying.
It will be very costly in corporate culture.
It doesn't have to be very costly, sir. That's where I'm going to disagree with you. If it comes as only charity, there will be limits to how much I can spend on palliative care. This has to be a patient and giving the choice to the patient. The emergency room, for example, Rajam's standard argument, I'll let Rajam say it herself, about why and how we justify palliative care in corporate hospitals.
So I also think, we need to think of health economics. Now we have young palliative care doctors who come out. They also need an incentive to work. How is his dal roti going to come from? So every way it's a specialty in medicine. Yes, it is not rocket science. It is high touch, low tech. But at the same time,
it is evidence-based medicine. At the same time, it is specialized. Yes.
Yes. And also what is important is that we need to integrate this at every level with every specialty, because there is suffering across the board. You yourself imagine taking your mother for an X-ray to a hospital. It is a nightmare. There is no parking, there is no wheelchair, there is the long line. So all this adds to the suffering. And imagine you're taking a gasping patient to the casualty, it is even more stressful. So the point what I'm trying to make is it has to be integrated. So like we cannot imagine a hospital without an emergency department. We should not in the next 10 years or 20 have a hospital without a palliative care department. Because be it oncology, be it neurology, be it CKD, be it cirrhosis, we do not have a solution for everything. For that 22-year-old, which I showed you in the beginning, she can't be sent to lung transplant if the father doesn't have the money. There is no charity which is going to be done for her. At the same time, she's a patient, she's suffering, her parents are suffering. Imagine losing a child. So they all need palliative care. The pulmonologist can do only that much. So it is important that everything cannot be free. At the same time, we use evidence-based. It is the science which is very important to communicate to the patient. And what is important also is that the talking, the narrative medicine is all healing for the patient and the caregivers, and also time saving for the specialist. Patients, there are difficult patients. They keep asking the same questions. You have 50 patients outside in your OPD. The palliative care integration leaves the patient satisfied because there's somebody to listen. And that, like I said, address the distress. We might not be able to solve it, but you can make a big difference by doing all this. So the multi-speciality team handholds the whole patient and the care. Because like I said, a COPD is diagnosed at 65, dies at 85. 20 years is a long-term association of chronically being ill, poor health, multiple admissions, losing his job, depending on his caregivers. Maybe son stops working because he has to 24 hours be next to the father. So it's frustrating for everybody. And there is compassion fatigue. So, we have to realize the importance of palliative care in every hospital, corporate, government, everywhere. Yes, I suppose if what is important is we actually fight for insurance for palliative care so that it is paid for, it is good for everybody, because finally the ones who practice palliative care are also doctors like you and me. So it's very important.
Sorry, that's such a great point that you made.
Go ahead.
There's one question that's come up from Parvati Nair about how to integrate palliative care into the public health system. Now, you mentioned Kerala as a model. I'll just give you one more example of Telangana, for example. Telangana has Arogya Shri. Now, Arogya Shri allows any patient with a cancer diagnosis about 3.5 lakhs worth of expenses taken by the state for treating their cancer. This could be surgery, radiation, chemotherapy. If the patient is diagnosed straight away at stage 4 non-resectable metastatic disease, they can still avail of up to 1.5 lakhs, which could go towards whether just palliative procedure like a colostomy, or it could go towards palliative radiation, and it goes to palliative care services. So, as part of the state's cancer management package, palliative care is part of it. So when you start looking at it as how would you address it state policy-wise, recognize the diseases which have distress associated with them. Kerala has another example. For chronic respiratory disease, any patient who has to be on oxygen and BiPAP gets an electricity bill subsidy from the government. That is several thousand rupees saved for that patient's family. That patient is going to need oxygen or BiPAP not for 1 year, 2 years, but for 5 years, 8 years. Add up that bill, they need a note from a government doctor saying that this person needs oxygen and BiPAP 24/7. The electricity bill will be out of proportion for this household. Just that 2,000-3,000 rupees saved makes a big difference. This is how we integrate it into the public health system.
Are we ready for the case? Anybody
Yes,
wants to
ma'am.
add anything? It's 7:30.
Yeah, ma'am. I think we can move to the case presentation for today.
Correct.
Yeah. We have Dr. Vijay Kumar joining us for the case presentation. I welcome you, Dr. Vijay Kumar. And Sangeet, kindly project his case.
Sure, ma'am. Is this presentation visible, ma'am?
Yes, Sangeet. Dr. Vijay Kumar, you can start.
Yes, madam. Yes. Good evening, everyone. Myself, Dr. Vijay Kumar. Currently, I'm an associate professor working in Mangalore in the Kanachur Medical College. So this is a case which I came across when I was practicing. So name of the patient was Mini. She's a female. She was a nurse by occupation. Okay, she was diagnosed with adenocarcinoma of lung. Okay, she actually presented with complaints of dry cough since 2 months. Also gives a history of weight loss and night sweats, and also she complains of breathlessness. Here, our major concern was dry cough rather than breathlessness. Okay, next. So she complains of dry cough since 2 months. It was sudden in onset, gradually progressive. There was no seasonal variation, but definitely there was a diurnal variation as present. She complains she had a breathlessness throughout the day and night, but it was more concerning during the night. So the disturbance of sleep was present. There was no positional variation in cough. Patient gives history of weight loss about 2 to 4 kgs over 2 months. Patient also complains of breathlessness only on exertion and relieved on rest. and there was no history of pulmonary tuberculosis or diabetes or hypertension in the past. So our examination was like there was a pallor was present, but there was no clubbing and there was no pedal edema. And on a respiratory examination, she had a left suprascapular, bronchial breath sounds was heard. There was no palpable lymph nodes was not there, and other systems like per abdomen and cardia was normal. So treatment was she was given an antibiotic. So ceftriaxone was given for 5 days, and injection pantoprazole was given. And initially it was a dry cough, but even she was given 10 ml of expectorant was given, and later on it was stopped. And to relieve the breathlessness, she was given nebulizer levosorbitamol, BD, and tablet N-acetylcysteine in case like if there was a mucus plugging or something like that. So we wanted to give N-acetylcysteine also. So we gave a mucolytic also. Routine investigations like CBC, RFT, LFT, ECG, and blood sugar levels were given. To rule out the infection, sputum for AFB, CBNet was done to rule out a mycobacterium infection, and we did culture and sensitivity as a routine procedure, and we did that did not yield anything. So later on we did a bronchoscopy, and I forgot to mention the CT also. There was I think 1 second. There was a consultation, and also cavity was there. So bronchoscopy was done. Ball was sent for AP, which was negative. Ball for CBNet was negative. But biopsy and brushing was done. So it was a biopsy yielded adenocarcinoma of lung. So before diagnosis, psychological aspects was like before diagnosis, she had a disturbance in her sleep, which altered her, sorry for the spelling mistake, which altered her sleep patterns and increased, daytime. Since she was not able to sleep in the night, she was having a increased daytime sleepiness also. Her quality of life was reduced. She was not able to attend her duty, and social outcasting was there. She can't, because of the constant coughing, she can't work, and she can't go and meet in the social or family gatherings. And after diagnosis of CA, she felt like helplessness, and sudden she was not that old, so suddenly she felt that her life has come to an end, and it was difficult for her to accept the diagnosis. And and she thought that it was cough for since 2 months. I could have seeked for a medical health much before. Such guilt she was suffering from. And she felt that she may die anytime. Those were the psychological aspects she was having. um, I don't know what is the exact criteria to put it into depression. So she was definitely was in the low mood. So probably she had a depression also. So, like after the symptomatic treatment, and when we diagnosed that she had a adenocarcinoma of lung, so we referred for an oncologist for the further management. Main concern was whether the diagnosis was delayed, or cough. The cough control was the major issue, because she was coughing a lot. And how we can improve the quality of life, and how I could have improved the sleep health was my main concern, and even it was a main concern of a patient also. Next, yes, somebody. A patient came with the complaints of cough, breathlessness, and weight loss, admitted for the same reasons. She underwent routine investigations and bronchoscopy. Biopsy yielded adenocarcinoma. Patient was in difficult to accept the diagnosis situation initially, and patient was also had a psychological issue after the diagnosis, and patient was referred to oncologist for the further management. Okay. So points to be discussed in class based on patient story. Like what else could have been done by a pulmonologist? I just want to know the panel of the people who are in this program to know, to suggest what else could have been done, and what palliative care can be extended to this patient as a pulmonologist was my points to discussion. And and also palliation is one part, and and also as a part of palliation, I wanted to know what respiratory symptom management, how beautifully it could have been done, and how to improve the quality of the sleep health, and ultimately how I could have helped improving the quality of our life. These were the my concerns of importance.
What was the stage of metastasis, or was it a resectable or not?
No, sir, it was not resectable. Like
You did not
there
mention
was
about the
no.
metastasis. That's why.
Yes, sir. There was no lymph nodes. Like palpable lymph nodes was not there, but definitely there was a mediastinal lymph nodes. Sorry, I didn't mention about CT thorax findings because it was
Yeah.
from my remote memory. I don't remember exactly.
Okay.
And yes, sir. Yes, sir. But definitely it was not resectable. It was very large. In fact, it was cavitated also.
Okay.
Yes.
So first of all, thank you. The fact that you realize that there could be palliative care is half the battle won. During my training, I would have never thought of palliative care. Is it okay if I stop sharing so that we can see everybody?
Yes, ma'am.
1 second. Yeah, great. So that is the first thing, palliative care. After having heard me, I'm sure the rest of you can, think of how can the integration take place, where should it take place, and how could we have improved. I think the first thing is the fact that you think about palliative care. Second thing is the biggest challenge is availability of access to palliative care. How many of you have access to palliative care in your hospital, stroke city, stroke state? So the IAPC website and along with Pallium India, we can send you the the directory of the full nation. They have tried to do it. So next time when you have such a patient, please access that directory, send to the palliative care, see what difference it can make to your patient's life. Just the fact that somebody listens, socially, she's low, isolated, all these issues really don't have a prescription. Patient has to be listened to, and patient has to be handheld, talked, spoken, etc. So please look at this directory that I think Hasmat has already shared. Very important, because the access to palliative care is another big challenge in our country when we talk about it, which is why we want each one of you to conveniently shift your gears from a specialist pulmonologist to palliative care for every individual patient. I mean, not all your patients need palliative care, but people don't cope well with certain diagnosis. What is important to remember is that palliative care is need based. It is not diagnosis or prognosis based. So just because I have stage 4 cancer doesn't mean I need palliative care. There are people who cope well. I'll need treatment for my distressing symptoms, but it is need based. There are people who freak out with the diagnosis of tuberculosis, and probably we have created that situation where now we have dangerous forms of TB. So TB also needs palliative care for pulmonologists. Need to remember that, because some treatments can be for 2+ years. You can lose a job, you can lose a spouse, so many things can happen. So that is important that you have access to palliative care. The second thing is, like this doctor said, where all could we have involved? So the social concerns, the anxiety, financially, the cough. The cough is something that can be treated well. Like I told you, it can start with codeine. Sometimes they say lung metastasis cough actually helps even with baclofen. But morphine is, in an ILD, morphine has been shown to have evidence, but gabapentin in a distressing cough. So you find out whether the patient has reflux, certain medications is causing the acidity, whether the patient is on ACE. So all those things you rule out, and then you start doing the palliation for cough with non-pharmacological and pharmacological. That pulmonologist can do himself. The talking, the hand-holding, the caregiver support, all that is where you can integrate palliative care. Anything else you would like to add, Rajni, and any of you now?
Yeah, I think, the case that you brought up is really interesting because it's a young woman with a lung cancer, and we are seeing more of non-smokers, lung cancers. These are patients with non-small cell lung cancers. And, we know that our patient population, depending on their EGFR, Alcross markers, may actually do well on oral medications for a longer period of time. If we look at one of the definitive papers on early palliative care in patients even with advanced lung cancer. So I have patients with stage 4 lung cancer at diagnosis, right? So these are unresectable stage 4 at diagnosis with their oral targeted chemotherapy or followed by targeted immunotherapy. Their survival could be as much as 3, 4, 5 years with symptoms. So I really need to address symptom burden. As Dr. Rajam said, you will address each symptom and say, what are my modifiable factors? In palliative care, we look at treat the treatable. You look at it nowadays in pulmonology also, we look at it from the treatable traits perspective. Approach it in exactly the same way. What are my treatable traits for each symptom? The symptom complex that you said, the psychosocial element is there for sure. The second part of it is purely physical symptom burden. You look at the breathlessness and cough, and that has been mentioned about the use of morphine and codeine. You mentioned the depression and low mood part of it. So that is actually going to be taken up in another lecture. But there are certain choices that we make even in antidepressants. Somebody who's not sleeping well, somebody who has a poor appetite and has breathlessness and has depression, maybe mirtazapine is a good idea. Maybe somebody who's, some of the patients will do better with sertraline if they also have anxiety or some kind of obsession, thoughts about, oh no, I'm not well, I'm not well. So these are similar to what we said earlier about the reason why we are not comfortable using opioids is we have not familiarized ourselves with it. So you also think of it in terms of how many specialists is this patient going to see? Every new consult adds a burden to the patient. So if we as pulmonologists familiarize ourselves with at least 3 or 4 antidepressants which are right for COPD, for lung cancer, for ILD, for TB, then we will be able to do the right appropriate treatment for our patients. So that's one thing I would like to say, because that will, and sleep, as you said, is a very important part. One more thing that we don't think of often enough, especially in cancer patients, is nutrition and rehab. So figuring out that part of it is also important. One commonly used scale, which you will be introduced to in the course at some point, is something called an Edmonton Symptom Assessment Scale that we use in palliative care. We look at 8 or 9 different symptoms, and it looks at overall well-being. So the most distressing physical symptoms and how tired are you feeling, your general sense of well-being and fatigue, all of that comes in. As a palliative medicine doctor also, I can't solve all the patient's problems. What I try to do with my palliative hat on as a pulmonologist is I will make sure I will address the primary disease, and I try to address 2 or 3 of the most pressing symptoms at each visit. When you work on it like that, you will be able to find the combination that works well for the patient over multiple visits. And that actually is what really leads to that, is postulated to lead to that better survival in patients with lung cancer with early palliative care. That's what Dr. Jennifer Temmel's work showed. This is before the advent of immunotherapy. Early integrated palliative care in lung cancer, even with stage 4 lung cancer, had better survival outside the hospital. That's because we are choosing to address a small symptom cluster every time and try to improve it. You improve 10 to 15% of that patient's symptoms, their quality of life improves dramatically.
Thanks, Rajni. Any more thoughts? Any more comments? Dr. Vijay, do you see yourself treating your next patient differently? Because this is another thing that Rajni had taught me beautifully about the handheld heart, you know, I mean, head, hand, and heart. You hear something, you start changing your prescription practices, and there are some things which changes the way you feel for your patients, because there's abundance of suffering that they go through, and how your practice changes. So even if you start thinking differently about your patients, that is purpose solved. If you feel that you've made that one slight change of how you talk to your patient, how you sit next to your patient, the words you use, and therefore how you can make the person more comfortable, that is, mission achieved. So that is going to be the big focus next couple of weeks on communications, because that is one very big 4-letter word that we all need to learn to do well, which is talk. And also, it's important that It helps us in every stage of life, not just with patients. It helps with, at home, with patients, in other vocations, in other phases of life. So that's the next topic. But thank you very much, Rajni and Pallium, and of course, all of you, because without all of you, it is very difficult for this program to be a success. So thank you very much for joining in the, during a working week, and look forward to seeing you next week.
Thanks, Rajam. That was a really wonderful talk. And it's so wonderful to see so many people joining in who are also involved in, they are doctors who are in teaching institutions. So I
Yeah.
really feel that this is going to be the ripple effect that we were hoping for, that each of
Yes.
you be a change maker wherever you're working at.
And like Dr. Rajgopal says, that by the time we need palliative care, that is, I need, there are these young doctors who are trained and who will probably handhold me and see to it that I also transition in peace. So thank you very much. Have a great evening, and see you all next week. Thank you. Back to you, Hashmat.
Thank you so
Thank you.
much, Rajam ma'am and Rajni ma'am, being a surprise and like a cherry on the cake. And thank you so much for joining today. And it was a very wonderful session. Thank you to all the participants for being very, very interactive, making it a wonderful session. Thank you, everyone.
Excuse
Over to
me.
you, Sangeet ma'am.
Yeah,
Yeah,
excuse
of
me.
course.
Only one thing, just wanted to know on a eco platform, I saw the various reading material, but it was for the first session, the guest lecture was not displayed or a PPT was not displayed. So I think whether I am missing somewhere from the eco platform, or is it yet to upload?
You want the PPT of the last talk, is it?
Yeah, that is
So
not there in
I'll
eco
just see if
platform.
Sujit has sent it to us, Sujit Rajan, and then we will send it to you, sir.
Yeah,
Apologies for that
Ma'am,
delay.
yeah.
I think I have already uploaded Dr. Sujit
It is
Raj.
not seen on
Can you
eco
just check
platform.
it?
It is not seen.
Let me
It is
check.
all
So,
reading material. It is all reading material is seen to be downloaded or viewed, but there is no guest lecture which used to be.
Actually, the PDF is uploaded in the reading material itself.
So can you
That's
send it,
Okay.
resend it separately just to avoid?
You can put it separately, the guest lectures and PPT, rather than with the reading material.
okay. Okay, sure.
It is easy to locate.
Okay, sure. Thank you.
Okay, thank you.
Point noted.
Yeah.
Okay,
yeah,
have a
Dr.
good
Sanjay
night.
Pandya,
Bye-bye.
please don't worry. Sangeet will reach out to you and he'll clear your doubts on that.
Yeah,
Don't
thanks.
worry.
Thanks.
Thank you. Thank you, everyone.
Thanks,
Bye-bye. Good
Rajni.
night.
Take care. All
Bye.
good?
All right, thanks.
Thank you, ma'am, for the presentation. Thank you, and Dr. Rajini for the presentation. Thank you, everyone, for joining the session. Thank you. Let's see you in the next session. Bye.